Please block your video transmission. Requesting all the students, please stop your video transmission. अपना वीडियो बंद कर दीजिए. And I request Dr. Sazal, please
Yes,
start today's webinar.
Yeah. Thank you, Deepak Zindal sir, and thank you, Bardhaman sir and Niranjan sir and Arun Moji sir. It's a great honor and privilege for me to start this session with all of the participants. We are from Global Celiac Institute. It's based on Belgium. And now we had the Asian chapter. We are working with you. So all the Asian subcontinent and South Asian countries is in our area. So we had already completed our live program at Delhi, and we have completed our exam also. So Delhi got already 12 Global Celiac Institute certified orthopedic medicine practitioner. That's great for us. So we are starting a small topic today. We will go for shoulder joint assessment at the way of musculoskeletal medicine. So it would be maybe a little bit different than all other assessments. We are based on the original work which developed by Dr. James Celiac several years before. All right, sir, we are starting. So in our module, we have previous time, we have 3 parts. That was module A, B, C. A was about our upper extremities and cervical spine. B is lower extremities, lumbar spine. C is advanced module and exam. But on request of Physio Help Institute, we have first time we have developed a new module that is called Certificate in Orthopedic Medicine Practitioner or Certified Orthopedic Medicine Practitioner. We will discuss it a little bit later after some time, after completion of this webinar. So first of all, I want to introduce you with our international teaching team. So we are several pupils working at the team. There are some of the physicians also working with us and some of the physios who are working with us. He is Dr. Pablo from Latin American side. He is Dave from USA. He is Ariel Ferrer from Latin American side. This guy is Alessandro. He is from Italy. And these are the 3 people who are the most senior people. Dr. Giuseppe, also Dr. Maurizio and Dr. Josica. They are from Italy, Croatia, and Slovenia. And here another one physician who is the injection expert. He's from Belgium. This was our first teaching team. And after that, I had joined as the youngest member of the team at 2017. It was during my international teaching diploma exam time, and it was at Belgium Dihan. Presently, this is our team. So all of those people are working different parts of the world. And my part is about Bangladesh, India, Pakistan, Sri Lanka, Nepal, and all of those Southeast Asias. So little bit introduction about myself. I have completed my graduation from Center for the Rehabilitation of the Paralyzed. It's a 200-bed hospital, spinal injury hospital. And we know this is the largest spinal injury hospital of entire Asia. Sister Valeria Taylor, she was founded this organization at 1971 after the liberation war of Bangladesh. And she's an Order of British Empire. And she is also working here as the coordinator of the organization. And you would be happy to know that she was once upon a time, she was directly working under Dr. James Celiac at St. Thomas and Guy's Hospital. And she's the person who gave us lots of motivation during my undergrad time at 2000 to 2004 to communicate with Orthopedic Medicine Institute and learn these things. After that, I completed my residency program from Ola Grimsby Institute, USA, Seattle. That is a Doctor of Manual Therapy program. It's a residency program. And now I am continuing my musculoskeletal research module under Queen Margaret University, that is at Edinburgh, UK. I worked in Bangladesh cricket team and also several different franchise cricket as well. So these are some Bangladeshi players, and especially whom I want to mention, Saqib Al Hasan. Everybody knows the best all-rounder all over the world. These also in some other arenas when different parts of the world we work for the franchise cricket. And I was really lucky to work with Stephen Smith at 2019. He was one of the players in our team. I'm also connected with Liverpool School of Medicine for orthopedic medicine researches. And I also completed my Society of Musculoskeletal Medicine programs under the supervision of Emily Goodlad and Jill Kerr. Both of those are faculty of Queen Margaret University as well. During those times, we learned from the Society of Musculoskeletal Medicine approaches beyond Global Celiac Institute. Finally, I'm working with Stephen D. Korinek from 2006. I started my work under him. I worked under him for nearly 12 years. After that, I appeared for the teaching diploma, and then I got permission to continue his work to you. So one thing he believed, rather than a teacher, I am your colleague who have something to share with you. So that is the scenario of what we believe in orthopedic medicine always. So several times when I have nearly 16 to 17 years of clinical experiences, and in those times we traveled several countries to represent orthopedic medicine. So every time we learn one thing, the question comes from our participants or delegates that I have done the Maitland concept, I have done McKinsey concept, I have done Kelton-Bourne, I have done Graston techniques, I have done Mulligan techniques, I have done Kinzo taping. Beyond that, I have done dry needling, I have done cupping, I have done some other taping, I have done some stretching exercises, but still I am not getting benefit from my patient. So what technique would be best? It's a difficult question to answer actually, because all the concept, all over the musculoskeletal system have lots of concepts, and every concept have its strength and weakness. So in orthopedic medicine, what do we want to tell? We want to tell you that first try to find out what is the diagnosis of the patient. When you know the diagnosis of the patient, after that, the treatment is very easy for us. Especially, I have also completed the dry needling from GMT, and also I have completed dry needling from Club Physio. I used to do a lot of dry needling, but before doing the dry needle, we want to go and want to find out why I am doing the dry needle. I also completed McKinsey courses. Before doing McKinsey approaches, I want to know why we are using these things. I have completed Mulligan several times under Deepak Kumar sir and other colleagues. Also, before the Mulligan approaches, I want to know what is the diagnosis. So several approaches all over the world is not going to give you the diagnosis. I believe there is only one system, that is orthopedic medicine, which is first going to give you a valid diagnosis, and after that you can choose a lots of treatment options. So the famous saying of Sherlock Holmes, what's the point performing techniques without proper diagnosis? Now come about the Global Celiac Institute. We want to tell you that this concept is going to give you a tool to find out about your proper diagnosis. Just like low back pain, there can be thousands of causes for low back pain, but according to orthopedic medicine assessment protocol, we want to know why the back pain is happening. And there is an honest question to everyone. A patient came to you today and they are facing some of the shoulder pain. And what you will think? What should be your treatment protocols? It can be radiating pain, it can be shoulder local origin, it can be from the cervical spine, it can be from the viscera, it can be maybe the patient have some trigger points, maybe the patient have some fractures, maybe the patient have some bursitis or tendinitis or tendinopathies, or maybe have some dislocations, maybe have some muscular weaknesses. A lot of things can happen. So if we go through a diagnostic protocol fast, then it will be very easy for us to know how to treat the patient. That is our motto in Global Celiac Institute. So the famous saying, what I want to share with you, that is told by Dr. James Celiac, the treatment can be learned in a day, but a diagnosis can take a lifetime. And he spent his entire life to give a valid diagnostic tool for the physios and physicians. Including that, I am also connected with Professor Jeremy Lewis, sir. I have completed his module as well. He had some different views, and that is very logical views. So sometimes, if you have some time, please go through that Professor Jeremy Lewis, sir's lectures. That is free on YouTube. He's one of the best person all over the world who talks about the new concept about the shoulder. His view is something different and really very challenging to all the old thoughts. So he is known as father of the shoulder. Please, if you have some time, you can go with Professor Jeremy Lewis as well. So I am one of the accredited Jeremy Lewis shoulder concept teacher that was organized by Prosper Physio. It was my great honor to be standing side of him. So beyond that, we are coming about our shoulder joint in the musculoskeletal medicine view now. So what we tell always, shoulder joint is the minefield of misleading diagnoses with lesions grouped under the broader non-specific heading of subacromial pain syndrome, impingement syndrome, rotator cuff instability syndrome, or frozen shoulder. These kinds of diagnoses, most of the time we try to manage or we try to tell to our participants or to our patients. But we believe after completion of orthopedic medicine, you will not describe your problems like that. Subacromial pain syndrome can be so many causes of subacromial pain syndrome. But after completion of this assessment, you can definitely tell this one is a supraspinatus or infraspinatus or subscapularis, or it is a bursitis, or it is a tendinopathy, or it is a long head of biceps problem. So we will tell you how to do that things. So you see that the mine is going to be blasted, but before that, we can detect the mine through the orthopedic medicine. So diagnosis can be difficult if lesions consist, but not impossible. So there are two kinds of lesion can be coexist, like a tendinitis and bursitis can be together. It can be together like a frozen shoulder and a tendinopathy. It can be together like a AC joint arthropathy, including that a secondary traumatic arthritis or primary arthritis. These kinds of things can be correlate together. But if we go through a step-by-step assessment protocol, we can find out about our valid diagnoses. So some of the statement, it's not uncommon to find a tendinopathy or bursitis in conjunction with secondary arthritis or arthrosis. It is common, it can be, it coexists. Another one thing, referred pain from cervical origin may mimic that from the shoulder, requiring assessment of the both areas to be sure of the origin of symptoms. So there are so many times we found the frozen shoulder patient, but we know that if we assess their cervical spine, we can find out it's really not a frozen shoulder. The pain is coming from the cervical radiculopathy or some of the internal derangement from the cervical spine. So it's also very common. In orthopedic medicine, we never go very fast. Our first time, we always assess our spine to rule out our cervical origin. And after that, we only go for the shoulder. Another one symptoms, shoulder pain may also be due to the pathology in the chest and visceral structures, making through the examination essential. So there are some red flags, there are some visceral origins which can radiate the pain to the cervical spine or radiate the pain to the shoulder, or the pain can be also radiate up to the forearm and from the up to the wrist also. So we need to go through that as well. Now, how you will diffuse the dynamite or diffuse the bombs? Knowledge of anatomy and the use of selective tension test are the incrimination of positive structures. So through the orthopedic medicine assessment, if you go with a selective tension test for every individual structures, then we can find out which structure is actually at fault. And finally, we go for the palpation. At the last end of the assessment, we go for palpation. We never go palpation at the beginning, because if we go for the palpation at the beginning, we become biased for some definitive structures. So our palpation would be at the last tool to determine the exact structures. So what we tell that shoulder is our most emotional joints. So in our body, we have two emotional joints. One is about our shoulder and second one is about our hip. But shoulder is the most emotional joint and the most mobile. It is the most mobile joint of the body. These two pictures we have taken from Jeremy Lewis sir. These are not my picture. These two pictures from Jeremy Lewis sir. Now, once upon a time, I got chance to work with Sania Mirza ma'am. She came to Bangladesh. You know that she is wife of Shoaib Malik Bhai. So Shoaib Malik Bhai was playing for my team. And she came in Bangladesh at 2010 and 11. At the time, we worked with her for some of our shoulder instability issues. So shoulder joint is the most unstable joint of the body, as it relies on more of its surrounding muscles for the stability rather than the shape of its joint surfaces and ligamentous constructions. So you all know that it is depending on the rotator cuff. and the rotator cuff can be very flexible, at the same time very vulnerable. So first of all, we are going to ask you what can be the shoulder joint diagnosis if there is any pain. So this time you can open your microphone and can tell me, I am telling you the question. A patient come to you with a shoulder pain. His pain is over here. This is the area where he had the pain. And he don't have any trauma history. He just suddenly had the shoulder pain before one night before he slept in some bad position, and next day the pain coming over here, and the pain is not radiating below the arm. Pain is only over his shoulder and the deltoid area. So you can open your microphone and can tell me what can be the possible diagnosis for this. Anyone want to share, sir? There are 78 people. So anyone want to tell anything about this? What would be in your mind? What would be the possible diagnosis for the pain which is here? Sir, anyone wants to tell anything? Yeah, at the chat box we find trapezitis, bursitis, middle deltoid pain. Yeah, it can be. The second person, Nirupam Bardhan, AC joint. The third person, Pooja Mehta, trapezoid stretch, overstretch, trapezoid ligament. Yeah. Another one person, MD Nasim Mahmood, subacromial bursitis. Yeah. Any other thoughts? Cervical region referred pain, yeah, it can be C3 dermatomal area, likely AC joint tissue. Hassan Rahman, sir. Hassan Al-Bonna to everyone. Rotator cuff injury, muscle strain, gallbladder related issues, radiations from cervical, scapula instability. Yeah, there are lots of diagnoses we are finding. That's very great. Now, little bit of things. We know that about the dermatome. The area what I have shown here, is a C4 dermatome and little bit of C3 dermatome. So mostly it should not be a rotator cuff lesion, because rotator cuff lesion is mainly C5 dermatome. So their pain should be in these areas, the rotator cuff areas or at the scapular area. Someone said AC joint and trapezoid stretch, that can be the most probable valid diagnosis. And someone said it is a cervical radiculopathy, that may be a very good valid diagnosis, positive diagnosis maybe. Now we are going to give you, there are so many diagnoses at the shoulder. First one, AC joint sprain, superficial. AC joint can sprain at the deep structures. So there are two structures, one is superficial, another one is deep. There is another one diagnosis, acute subdeltoid bursitis and chronic subdeltoid bursitis, but the clinical characteristics of acute and chronic is entirely different. Not a small amount of difference, it is entirely different. If we tell about acute subdeltoid bursitis, there can be some trauma history, or there can be some overpressure history, or it can come from a calcific tendinopathy, but it has a spontaneous evolution time, 5 to 7 days, maximum 10 days, severe pain. After that, it will go, the pain will subside gradually, and after 6 weeks, it will entirely abolish as a spontaneous evolution. No pain would be continued. But if it's chronic subdeltoid bursitis, that scenario is completely different. This did not come from the acute subdeltoid bursitis. Acute start as acute and finish as acute. It never become chronic. When there is a chronic subdeltoid bursitis, so many diagnostic options can come to us. It can be due to the tendinitis or tendinopathy. It can be due to the secondary arthritis or primary arthritis. It can be due to the AC joint problem, or so many. And it really don't have any spontaneous evolution. If a people have chronic subdeltoid bursitis, he will have that for long period of time. It will not subside. It will not subside with time. Now we can come with subcoracoid bursitis. Another one thing, traumatic arthritis could be, shoulder arthrosis could be, Immobilizational arthritis could be, steroid sensitive arthritis could be one reason for the shoulder. Frozen shoulder can be. Then we can come for supratendinopathy. Supratendinopathy can be in 3 different places. One is at tenoperiosteal junction superficial part, another one can be tenoperiosteal junction deep part, or another one can be musculotendinous junction. At the same way, infra, subscap, pectoralis, lattice, teres minor, teres major. It can be deltoid tendinopathy as well. It can be coracobrachialis tendinopathy. After that, it can be shoulder anterior instability, shoulder posterior instability, anterior capsular adhesion can be. It's a very interesting diagnosis. Coracoclavicular ligament sprain can be, snapping shoulder can be, slap lesion can be, mononeuritis of the suprascapular nerve. Another one very interesting diagnosis, which we only cover in orthopedic medicine. Then mononeuritis of the long thoracic nerve could be, mononeuritis of the spinal accessory nerve. It can be axillary nerve palsy. It can be contracture of the costocoracoid fascia. It can be the first rib fracture, or it can be the Clay-Shobler's fracture. So there are nearly 36 diagnoses may come from the shoulder, but it's a common physio disease that without doing the diagnosis, we run behind our techniques. Technique is always good, always good, always good. But before that, we really need to find a valid diagnosis. So we want to share this thing with you. So as long as you are staying inside of your comfort zone, you will be very fine, you will be very good, but you need to come out from the comfort zone. You need to cross your fear zone, come to the learning zone, and then go to the growth zone. This is the main work for the orthopedic medicine. We want to think in some different way. Just like the world medical community thinks, we little bit want to think in that way as well. Okay, now come about another one thing. James Syriac told, arthritis. History is very important. It helps us to determine the stage of an arthritis, but tendinitis or tendinopathy, history is less important. Across all ages, most frequent musculoskeletal complaint, 7% is at the shoulder after back or knee problems. So shoulder is a very common area in our day-to-day practices. So why the history is important when it's an arthritis issue? Because we know any kind of arthritis have a spontaneous evolution. So if it is arthritis, traumatic arthritis, 8 to 12 months is our spontaneous evolution. If you don't do any treatment also, the spontaneous evolution will cure the shoulder. But if it is a tendinitis or tendinopathy, there is no spontaneous evolution at all. It can continue years after years, or maybe months after months. People will not get any benefit from the condition. So history is important to determine the tendinitis or arthritis. Now, shoulder joint complex, you all know these things. It is glenohumeral joint, acromioclavicular joint, sternoclavicular joint, and scapulothoracic joint. These are the 4 things we cover at the shoulder complex. Now, just have a look one thing, how much power we can produce from our shoulder. It's a very powerful joint of our body. So a ball from Shoaib Akhtar, we all know that he can throw it, he can bowl it at the 160 kilometer speed. So have a look the ball.
Lake Kelly. Pretty close there. Oh, that's 4. Very, very good.
The wicketkeeper cannot control it, so the ball goes outside and it gives a 4. And you can see the basketball pitcher as well. They can throw it in its very speed.
2-2 pitch. Swung out and missed.
No one
He
can see
struck
that.
him
It is
out.
more than 160 kilometers, nearly 170.
Still don't score.
So this one may be 170 kilometer per hour. So shoulder velocity is 900,000 degree per second. Cocking ball release is 80 degree in 30 microsecond. Deacceleration or eccentric brake is 5 lakh degree per second square. So these are the things about our shoulder can produce. And to find out the diagnoses, you all know that you went through a lot of orthopedic tests. You have studied the David J. Magee, and I have studied the David J. Magee, and everyone have studied the David J. Magee, and we learned a lot of tests. But recently, Dr. Chad Cook have found a new thought. He evaluated 870 tests and 1,500 references, and he found only 4% of tests are standalone, and only 4% were scored as having high clinical utility. So all the time when we spend to study those orthopedic special tests, maybe or may not be valid at all, or maybe after a few years it would be completely invalid. Professor Jeremy Lewis sir is already questioning about that, and lots of other researchers are questioning about that. So we need to go through some different scenarios. We need to go through some different assessment parameters. We need to go with some cluster of things. So about the bursa of the shoulder, we know that there are so many bursas which is related with the shoulder. First one you can find subcutaneous or subacromial bursa. Then second one, subacromial bursa. Third one, subdeltoid bursa. Fourth one, subcoracoid bursa. Fifth one, subscapular bursa. Sixth one, subinfraspinatus bursa. This is not only the last, maybe some people have some anatomical variation and may have some more bursa in their body. So it is very difficult to find out which bursa is going to give you the pain. So you can see this picture is taken from, this is not our copyrighted things. This picture is taken from the books by the permission. So here you can see the deltoid bursa is here. Subdeltoid bursa is here. It covers two areas. One is acromial area and the deltoid muscle as well. So one of the common reason of the subdeltoid bursitis, we will show you some picture after some time, and you can understand why without any trauma subdeltoid bursitis can happen. So this is the bursa, and this one is our acromion, and you can see the ligament here, acromio, and this one is coracoid process, so coracoacromial ligament. And here you can see there is one bursa, subcoracoid bursa, and subacromial bursa, and subdeltoid bursa. These three bursa are most commonly affected during our sports activities. Here you can see also there is subscapularis bursa is here. This is also another one which we found during the sporting activities. The thrower, they have some problem in subscapularis bursa. Now you can see some of the pictures. These pictures are taken from George Chahala sir. He is an American orthopedic surgeon and sports surgeon. Lots of ligaments are covering over the shoulder joint, and all of those ligaments have their own works and own values. So if there is any injury over any of those ligaments, it's not the end of the story. Nowadays, with the rehabilitation perspective, we can work with without the surgeries, or after the surgeries, we can also work. So if one of the ligament is ruptured, it's not the end of the story. Sometimes some new researchers is telling us that rehabilitation is as effective as surgery for the shoulder. And most of the shoulder surgery don't get the satisfactory results because maybe the injury, what we found at the MRI, may be not the cause of the pain. So this is the bird's eye view. What we want to refer here about the rotator cuff muscles. So you can see the supraspinatus, subscapularis, and infraspinatus, and a little bit down teres. These four muscles. So all of those four muscles, previous time we thought that they have different origin, but now we know may they have different origin, but their insertion is same. So these all are insertion which is related with one to another one. So everyone is connected with each other. These all have the same insertion. Have a look about this picture. This one is also taken from George Chahala sir about his dissection work. So he had given that this is teres minor, this is infraspinatus, this is supraspinatus. And if we saw from the behind anterior side, this is subscapularis, this is supraspinatus. And you cannot find the different, you cannot differentiate the different between the insertion. Everyone is inserted with each other. So it is very difficult to find out what is the exact structure have the pain. Here, if you want to go, you can see also the infraspinatus and subscapularis, both of those are also connected with each other. That is also another one problem. This one is also the dissection of the shoulder joint. In between the shoulder joint, you can see the superior glenohumeral ligament, middle glenohumeral ligament, and anterior lateral glenohumeral ligament. Those previous time we thought that they are different structures, but now we know all of those have the same connection. One is connected with other, everyone is connected with each other. So these things give us a lot of difficulty to find out which structure exactly facing the problem. And this one we want to share with you, deltoid. Deltoid have several tendinous bands inside, and these are the bands of deltoid muscles. This could be a reason for chronic subdeltoid bursitis. This picture is also taken from George Chahala sir, his dissection. So here you can see these tendons can create some pressure over the bursa, and due to some other causative factors, the bursa can have the chronic bursitis. This muscle you already know, teres major, teres minor, and latissimus dorsis, and biceps tendon. So several times you can find that slap lesion is over there, and at the MRI tells you that there is a slap lesion, and player becomes so much surprised that how I will be okay. But believe me, in cricket, in Bangladesh cricket, I am working for several years, and several international cricketers I had worked with. All the pace bowlers have several multiple injuries at their shoulder. Several of them have 30%, 40%, 50% tear of their shoulder tendons, and regularly they are performing without any pain. So maybe someone goes tomorrow to a physician or some other specialist, and they do an MRI, and after that they can tell that you have these injuries, and those words will give a lot of trouble with the player's head. And maybe certainly after those words he heard, his pain can start it. So we need to be very careful when we use our words. So these all muscles are very close, and it is very difficult for us to find out which is at the fault. So we will use the orthopedic medicine assessment. Chronologically, we will go one after another, and one after another, and we will collect all the puzzles from our assessment. And finally, we will correlate with one puzzle to another one puzzle to find out a valid decision. Here you can see there are so many bursas. This is one bursa, this is one bursa, this is one bursa. All three bursa are covering the shoulder areas. So these are the anatomical structures, what we have discussed a little bit. Now, a patient came to you about the shoulder. So you will ask 9 questions to them. To find out in the musculoskeletal medicine way, you need to ask 9 questions. So what is the first question? Question 1, where is the pain? Now the question is, can we rely on dermatome only? Some books tells us that we cannot rely on dermatome. Some books telling us, yeah, we can rely on dermatome, but maybe person to person have different dermatomal structures. But one thing is very common, the shoulder, this area is naturally a C4 structure. After that, this area is C5 structure. This area is C6 structure. This area is C7 structure. This area is C8 structure. This is T1 structure, and this one is T2 structure. That is common thing for every human being. So when the patient come and tell us about the pain, we will try to find out which dermatome the pain or neurological findings or the tingling sensation or pins and needles or paresthesia is traveling. If it is from rotator cuff area, it should be on C5, C6, C7. It should not be at C8 or T1 areas, because rotator cuff did not carry the pain to C8 or T1 areas. C5, 6, 7 is the main area for rotator cuff. But acromioclavicular joint, it's a C4 structure. So if there is any issue about the acromioclavicular joint, it should not carry to the C5. It should be on C4. And you know that about the shoulder joint, this is commonly 2 nerve structures. One is axillary nerve and another one is suprascapular nerve. Suprascapular nerve carries nearly 70% of the things, and axillary nerve carries 30% of the things. So a shoulder problem should not go to T1, T2 structures. So dermatome can be a very valid tool for you to primarily determine which area should be. So this one is your first puzzle, which one comes from the patient's history. Second one, question 2, was there a trauma? Why we will ask that trauma? A trauma can create a traumatic arthritis or bursitis or rotator cuff lesion or a fracture, but not necessarily always the rotator cuff lesion comes from the trauma. Everyday overuse can also be a trauma. The people who do overhead activities, who do writing the things on their blackboard or some other areas, they also have some trauma. like the physios, like the physical therapist who always work the manual therapy practice for several years, they may also have some trauma on their shoulder. They may also have overuse injuries. The senior physiotherapist who is more than 45 to 50 years old may have some chronic bursitis. But when there is a direct hit, we can think about traumatic arthritis. So this one is our second puzzle piece. Third one, question 3. How can you influence your symptoms? This one is very important. This one gives us a correlation with their story, and this one gives us a clinical images. So we know about the classical and hallmark features of the tendinitis or tendinopathies. So what is that? When we start our work, during that time, the people will have some pain. After the body is warmed up, after some times the pain goes away, and immediately after completion of the work, the pain will come back within 24 hours. Including that, when you try to do the exacerbation of your works, just like you were playing some tennis and suddenly you thought that you will play some hard smashes, you want to speed up your shoulder. That time may also you can feel some pain. So this one gives you some idea about the tendinitis or tendinopathies. So the third question was another one puzzle, which comes from our history. Now the question 4, since when? That means how many days you are feeling the problem. This one is very interesting in our orthopedic medicine because we know everything, every shoulder related things, just like the arthritis, any kind of problem about the shoulder joint, not about the rotator cuff, have a spontaneous evolution. If it's the acute subdeltoid bursitis, 6 weeks spontaneous evolution. If it is primary frozen shoulder, primary traumatic arthritis or secondary traumatic arthritis, that's time you will found 6 to 8 months or 8 to 12 months, or sometimes 12 months to 24 months time frame, what we will discuss during our main courses during our orthopedic medicine. So the question number 4 is another one important structure to find out the spontaneous evolution things. If a patient already traveled 3, 4, 5 physios and finally come to you at the month of 9 and he had a traumatic arthritis, you can tell that, yeah, in this next 2 months, I am going to make you cure. And if the patient comes at the very beginning and he is not agreed to take the injections at the shoulder joint, then you know that this patient needs long time to be cured because spontaneous evolution will take a long time. Now, question number 5, are there other joints affected? This is very interesting one. If the patient have multiple joint affected, that time we can think about some systemic diseases like rheumatoid arthritis or some other seronegative arthritis. So seronegative arthritis patient always have bilateral problems and the small joints affected fast and early morning stiffness and blah, 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 blah. So this is another one very important question, question number 5. Now, question number 6, if the patient have a surgery at the shoulder or associated areas. Always when there is a surgery, the capsular pattern would be superimposed and it will give you a capsular pattern. So we all know the capsular pattern of the shoulder joint. Maximum limitation of lateral rotation followed by abduction followed by medial rotation. So any patient, when they go underneath the surgeon's knife, they obviously have these characteristics. So maybe the patient have done the rotator cuff surgery, but now the patient comes to you with a capsular pattern. So you should not treat the rotator cuff lesion only, you should treat the capsular pattern as well. And several times when the patient have a rotator cuff issues, they develop capsular patterns. This is vice versa. Now the 3 important questions. This question will help us to determine the stage of the arthritis. Question number 1, can you lie on the affected side? If the patient can lie on the affected side, the arthritis is not that serious. If the patient cannot lie on the affected side, the question becomes positive. Second one, does the pain refer below to the elbow? If the patient have only shoulder pain and including the C4 structures and little bit of C5 structures, but still not below the elbow, it gives us some idea that this patient have moderate level of arthritis, not the severe level of arthritis. The question number 3, do you have pain at rest? If the patient have pain during the rest, that means it's a severe arthritis. If the pain don't have If the patient don't have pain at rest, that means it is primary level of arthritis. So all those puzzle pieces we make together, and if we found 3 favorable answers, then the patient have stage 1 arthritis. If we found 3 unfavorable answers, the patient have stage 3 arthritis. In between, 1 favorable, 2 unfavorable, or 2 unfavorable, 1 favorable, whatever the things are, that is combination, that is stage 2. So if the patient are in stage 1, what should be our treatment of choice? If the patient is a stage 1 arthritis, we should do a strong mobilization with capsular stretching with active exercises, because we don't want to go them throughout all the evolution. Or we can give them a intraarticular injection with depomedrol, with 40 milligram depomedrol, including that 4 to 5 ml local anesthetics. Some countries we can do that, some countries we cannot do that. So it varies from countries to countries, different laws. But this stage 1 patient is very good responder with the injections. Now the patient come with a stage 3. This time manual therapy is completely contraindicated. So whatever you do the capsular stretching or anterior to posterior glide, posterior to anterior glide, these things is not going to help the patient. This patient may have only 2 kinds of treatment. First one, a series of intraarticular injection, not a series of intraarticular injections with depomedrol. And the second one, as a physical therapist, we can do the distraction technique only, which will give them some relief from the pain, but manual therapy is contraindicated. So this is very important characteristics, what we need to know when we go with our diagnosis and the assessment with the orthopedic medicine things. A little bit of break. This one is at Belgium. These are the, some of my course mates. When we do our teacher training program that time, it's a special shop where we get the French fries, and we need to book the things from 2-3 days before. This is very special French fries. All right, this is the shop, very small shop, but we need to take appointment earlier. Now you can see this one is about how we can create the scapulation. We know that Bangladesh, India, Pakistan, we all are very familiar with the cricket, but the European people, they don't know the cricket. These all are our teaching staffs. We have some fun over there. Now we are really coming at the point of shoulder functional examination. I know that theoretical part is a little bit boring and everyone feel bored for that, but our purpose, we have added the video to get some fun only. So when we found a shoulder patient, our functional assessment, what we need to consider. First one, painful arc is a very important one. We only do 3 kind of tests. One is active test, one is passive test, one is resisted test. These are the 3 things. And in those 3 things, we try to find out lots of puzzle pieces. And finally, we correlate all the puzzle pieces with each other to find out a valid diagnosis. And you know that orthopedic medicine or serious shoulder assessment is highly reliable. Selecting the diagnostic categories, its kappa value is 0.87. So all over the world, we can strongly say that orthopedic medicine or serious assessment is the most valid shoulder assessment. So the reliability, these are some scientific structures which you can take a snapshot from here, or I'm sure that the organizer is copying these things. They are recording these things. So you may have the recorded copies that can be also, so you can have those scientific articles. This is also given, not right now, several years before. We already know the highly evidence-based categorized levels of arthritis on basis of the infill. So in orthopedic medicine, infill is one of the very important things, what you found from your patient's body. We want to give you some small description why we will do the active test, passive test, and resisted test, why we don't do the accessory mobilization. One famous study was there that is also done by some other clinical clinical stuffs that mobilizing the joints. Maybe we really did not mobilize the joint throughout our careers. Several people have tried to mobilize the lumbar spine, cervical spine, and sometimes we also mobilize the L5 lumbar spine as well. But the clinical truth is not a single one person throughout their entire life become closer to the L5. L5 cannot be palpable to anyone's body how skinny he or she is. Even the second one, cervical C7 spinous process, cannot be palpated throughout our career. The best person who is best manual therapist, they come closer to the C7 cervical spine, still they are far from nearly 1 centimeter away from the C7 cervical spine. And we know that we want to do the grade 1 mobilization and grade 4 mobilization. And in between those grade 1 and grade 4 mobilization, it is only soft tissue deformation. McGregor Hill had already confirmed it at the 2001. And after that, several studies also done in several times. Still, it is the same. No more, it is only soft tissue deformation. It is not the mobilization of the structures. So if you go through orthopedic medicine books, you will find a detailed about that. So we did not add the mobility test in our assessment. We only rely on active motion, passive motion, and resisted motion. So when we do an active test, our 3 parameters we want to know, one is pain, another one is range of motion, another one is willingness to move. So throughout the active motion, there can be pain. We want to know how much range of motion they have, and we want to know if they want to move or not. Why? If the patient have an acute subdeltoid bursitis, they will never interested to move the shoulder up because that is so much painful. It is not that they have some other injuries. It is inducing so much pain that they don't want to take it up. About our passive test, we check our inert structures and we have 3 parameters. First one, pain. Second one, range of motion. Third one is infill. These 3 things are very interesting about our passive tests. We will interpret that at the last. Finally, you come for the resisted test. We check our contractile structures. We found 2 parameters. One is pain, another one is weakness. After that, if necessity, we can go for accessory test, that is cluster of the test, not a single test, because we don't believe one single test can give you a valid diagnosis. We always use the cluster of the tests to find out our diagnosis, valid diagnosis. So shoulder examination, the original version, what we are using that, and that is a patented assessment form, which is patented by Global Celiac Institute. No other organization of the world have this assessment form. So that is only developed by Stephen D. Koenig and his team. But the good news is we had discussed with Deepak Zindal sir and Physio Health Institute. They will give you free of cost. They will give you the assessment form after this webinar. So I believe you are connected with our WhatsApp group. So you will get the shoulder assessment form over there. Okay. So first test, we tell the patient to do a free shoulder elevation. So what is shoulder elevation? The shoulder abduction is called as shoulder elevation in orthopedic medicine. So when the patient do that, from this one single test, you can find out so many diagnoses. You can predict so many diagnoses. What are the variables during this test? First variable is pain. Second variable is range of motion. And we know that shoulder joint is a complex joint and it has 3 kind of movements. First 60 degree, first 90 degree is a glenohumeral abduction, which is done by the deltoid muscle and supraspinatus muscle. Second 60 degree, that is rotation of the scapula along with the thorax. This one mainly done by serratus anterior and upper trapezius. And third 30 degree of the glenohumeral motion comes from the glenohumeral adduction, which done by the pectoralis major. So these are the 3 parameters, but we don't know when which one happens. It is a combination of all 3 movements. So during this movement, if we found any painful arc in between 30 to 60, some books tell 45 to 60, some books also tell 60 to 90, some books also tell 30 to 120. we still don't know which is most valid, but if we found any painful arc in between 30 to 90 or 30 to 100, we think it's a supraspinatus injuries over there. It can be, manual therapist can describe it as an impingement syndrome, but after completion of this program, we will tell you there is nothing which is impingement syndrome. There is nothing which is really impingement syndrome, because when a ligament or when a structure is moving with the shoulder joint structures, that is not the cause of the pain. Perhaps the ligaments and tendons become very happy to be touched by the acromion angle or some other structures. It is something else. This is not the impingement. So when the patient do both of the arms together like this, that time we know it is normal. But if one arm is 180 degree, another one arm is little bit less than that, actively, but passively it is okay. That time we can think about a mononeuritis of the shoulder. We will discuss it in our live courses with a lot of discussion. Second one, if another one shoulder comes up to full of these and another one is come up to this, then we can also think about another one mononeuritis that can be a long thoracic nerve. And if the patient have like this one, then we can also think about another one mononeuritis that can be for a suprascapular mononeuritis. So these are the variables from this active test we can found. And finally, if the patient is not interested to take their hand up, or even if they take it up, they hold it by another one hand and gradually take it down, and they have a severe pain of their shoulder, we can think about a acute subdeltoid bursitis. But this is only prediction. After completion of our full test, we will find out the confirm answers. After that, we are going for our secondary test, that is our passive elevation. When you do the full passive elevation, if that one gives us in-range pain or throughout the range pain, that can give us some idea about supraspinatus deeper part injuries, because supraspinatus deeper part give the pain during our passive elevations. All right, we are coming for painful arc. So there are two areas of painful arc. One is in between and one is at the end of the range. If the end of the range painful arc is over there, we can think it is coming from our acromioclavicular joint, but still we are not confirmed. After the assessment, we will patch up our puzzle pieces. Now we come to rule out our shoulder capsular patterns. So we block the scapula with our thumb and we take it up to 90 degree. If the patient can take it up to 90 degree, then we can rule out our glenohumeral abduction things. If we can't go up to that, then the traumatic arthritis or any kind of frozen shoulder or any kind of glenohumeral problem is coming in. Now we are going with passive lateral rotation. This one is very interesting thing. When we go for passive lateral rotation, that time we can compress some subscapularis bursa or also the subdeltoid bursa, and it can give us some idea about the chronic subdeltoid bursitis or subscapularis bursitis. So this one is important. After that, we go with medial rotation. During this medial rotation, which is very important structure about the anterior structures and about the posterior structures as well. During the medial rotation, it gives us the confirmation of the stage of the arthritis, because at the beginning of the arthritis, the medial rotation is not restricted at all. At the second level, it becomes restricted. At the third level, it becomes severely restricted. So this one is very important parameter for our diagnosis. So arthritis or arthrosis, another one interesting thing. Several years we are using the word arthritis, but nowadays we know arthritis finished off and then the arthrosis carries years after years. So the good term should be used in our diagnostic parameter is arthrosis rather than arthritis. Now come about the selective tension test. So when we do the selective tension test of resisted abduction, we are testing supraspinatus and deltoid, and we are also testing the C5 nerve root. When we are doing resisted adduction, That time we are testing pectoralis, latissimus, teres major, teres minor, and C7 nerve root. After that, when we are doing resisted lateral rotation, we are testing infraspinatus, teres minor, and C5 nerve root again. When we are doing resisted medial rotation, we are testing subscapularis, teres major, and C5 nerve root again. Then we go for resisted flexion. This time we are testing two of the muscles, biceps brachii and brachialis. And with the supination and pronation of the forearm, we can differentiate the biceps brachii or brachialis. This is also a C5-C6 nerve root test. After that, we go with triceps. This is very important because during the triceps test, if the patient complains about shoulder pain and that radiates to the C5 dermatomal area, that gives us the idea that somewhere, somehow, the subacromial or subdeltoid bursa is going to be impinged or compressed. So we will do a differential diagnosis, take the patient on bed, give a traction, take the arm on 90 degree, and then we test it again to differentiate the bursitis from the triceps muscles. This is also a C7 nerve root test. After that, we will make the final accessory test. This one is a scarp test, but during the scarp test, there can be three parameters. It can be a C joint problem, it can be a subcoracoid bursitis problem, it can be a subscapularis stenoperiosteal caudal part problem. How to differentiate those three? If it's a subcoracoid bursitis, then we have some different test. If it's a subscapularis stenoperiosteal caudal, our resisted medial rotation would be painful. If it's a AC joint problem, then we may have a painful arc at the in range of the shoulder, and we may have some palpatory pain over the AC joint. So these are the common parameter of our shoulder assessment. Now I am adding the video so you can see the full scenarios of the assessment. That one done by Stephen DeConnick. So it's a copyrighted video, but still we are sharing with you because you need to know. And we have to get the permission from the Stephen to share this one. So have a look. I'm starting this one. Few seconds. I need to start it again. Yeah. I hope it will be okay now. The presentation and Zoom is a little bit disturbing. So what I'm going to do, I'm going to give it again. It will take few seconds. Yeah, I hope it will be okay now.
Active elevation, we assess pain and range of motion. Passive elevation, again, we assess pain and range of motion. Grasp the elbow, not the forearm, in order to test the elastic end feel. Then we look for a painful arc. We ask the patient to lift his arm and to inform us about possible pain. Where and when is it felt? A painful arc can also be provoked in other ways. Passive test for the glenohumeral joint. Compare both sides. Abduction. The thumb fixes the inferior angle of the scapula. The arm is raised passively until we feel the end of the glenohumeral movement. The scapula remains fixed. We assess pain and range of motion. Lateral rotation. It is important to immobilize the patient's contralateral shoulder, and the therapist has to step slightly backwards to reach the real end of range in a very mobile patient. We assess pain, range of motion, and end feel, elastic. Medial rotation. Avoid doing a retropulsion instead of a medial rotation. Therefore, we block the upper arm with our trunk. We assess pain, range of motion, and end feel, elastic. Don't stop at the first pain, because a painful arc on medial rotation is possible. Resisted test, we assess pain, and weakness. Adduction, we mainly test pectoralis major, latissimus dorsi, teres major, and minor. Abduction, we mainly test the integrity of supraspinatus and deltoid. Lateral rotation, we ask the patient to keep his elbow against his body and not to abduct his arm. The resistance is given proximal from the wrist. We test infraspinatus and teres minor. Medial rotation, we mainly test the integrity of subscapularis and teres major. Elbow flexion, we think of biceps and brachialis. Elbow extension, we think of triceps.
So that is about our basic functional examination. After that, we can go through our accessory examinations. Now we are coming with the questionnaire sessions. Before that, we want to say, several years people are telling that it's an impingement syndrome, But after now, if someone tell you that it's an impingement syndrome, you can tell them, stupid, read Williams Syriacs and then define me what a specific diagnosis. It's not impingement syndrome. It's just some of the diagnosis, what we cannot do, then we tell it's an impingement syndrome. We will go for a small description now, and after that, we will come back to the questionnaire session. So you already know that we have completed our first batches of the orthopedic medicine, and now we are coming with a new idea of the orthopedic medicine structures, because we found to go through 5 times to India, and also all the participants coming from different parts of the India to the Delhi is very difficult for everyone. And due to pandemic, we found the new ideas of the online hybrid modules. So what we have done now, there will be only 2 modules now. Module A, at the beginning, we will cover all orthopedic assessment from all peripheral and spinal joints, and we will cover all the clinical reasoning things. So in 5 days, we will cover shoulder joint, elbow joint, wrist joint, hip, knee, ankle, cervical, thoracic, lumbar, spine, and sacroiliac joint. All 10 joints assessment and the clinical reasoning we will complete at the first cohort. Then you will find an online platform to know and to study all of those clinical parameters and how to correlate all of those things for 3 to 6 months. After that, we will meet together for a module B. There will be treatment and management of all peripheral and spinal joints for 4 days. In those 4 days, we will cover every treatment, hands-on treatments for the joints and spines. And after that, the final day, the 10th day, we will go for a MCQ written exam followed by a practical exam. All the people who complete the written and practical things, they will get COMP, Certified Orthopedic Medicine Practitioner characteristics or entitlement. Now, how you can go further with this study? This is not the end of your study. We are going to tell you how to develop the things. Just I am sharing with you some of the websites. Just few seconds. I have already done that. I'm showing you. After completion of that, what you can do, you can go with Society of Musculoskeletal Medicine as well. This is UK-based organization, so I believe all the freshers who are joining our these webinars, who want to work at the UK in musculoskeletal field, it is mandatory for them to work with the Society of Musculoskeletal Medicine's characteristics or any university's musculoskeletal medicine parameter to work as a musculoskeletal GP. So the good news is, when I complete my EDGOM module, that time SOM did not allow us to give exam directly. They tell us to complete their full module. But now you are enjoying a privilege to complete our module, and then you need not to appear any part of SOM. You only need to write a 5,000 words reflective essay and need to pay a fees to SOM to become a diploma holder of SOM and become a member of Society of Musculoskeletal Medicine UK. So we have a written agreement with SOM. So the people who complete the COMP program can directly get the diploma from Society of Musculoskeletal Medicine incorporated with Queen Margaret University. So this is the first things. So how much money they need? The SOM diploma is total £3,000 cost. Their diploma cost £3,000, and you are getting it in a very affordable price in Asian markets. Now the second one, you still did not do any masters, so you want to do a masters, or you have a masters, you want to do another one postgraduate diploma in a specific manner. We have that for you. In collaboration with Queen Margaret University, Edinburgh, we have musculoskeletal medicine program for you. So you can join the musculoskeletal medicine program directly with our COMP. So when you complete your COMP, you will go to SOM and submit a reflective essay, and then you need to submit 2 reflective essays. One is with the spine, one is with the periphery. So total 5,000 words, your post-graduation certificate is complete. At UK system, you have 120 credits for the postgraduate diploma. So first 60 credit you already completed. Second 60 credit, what you need to go through only 3 courses. One is injection therapy, that is 20 credit. Another one is advanced musculoskeletal practice, that is 20 credit, and research methodology, that is another 20 credit. After that, you can complete your entire post-graduation diploma. Now, if you want to get a master's, you can apply to Queen Margaret University, you can meet with the supervisor, and you can submit a dissertation of 15,000 words under your supervisor, you can get a master's. So that is the option from our side, what we can offer to you about our study. Now we are going to tell you something different, how the online parameter works. So after completion of the first module, when we do our all practical things, now clinical reasoning we will discuss, and you will also found through this website. This website we have developed. Here, just I am showing you tips, how can I define an impingement syndrome, this one. So this is a video demonstration directly done by Stephen. So you can give the MCQ question answers. So have a look.
Shoulder impingement is a very fascinating diagnosis. Well, in fact, impingement.
After that, you can go all of those things. There are 47 lessons here throughout all the joints and all the things. So every joint we have covered, just like here, the value of inspection, why irrelevant. Stephen has given a clear demonstration of those things here.
Inspection, opening your eye.
So it's a hybrid module program. You will follow all of those things
Inspection
and can found a very good clinical reasoning. Previous time when we do a single session discussion, that times it becomes difficult for some participants to understand all of those things, but we prepared the online learning platform so you can go through several times with the platform to get your answers. And we will always be with you with the Zoom links or some other meetings or some other platforms. We can give your answers. So that's all about our webinar, and that's all about our COMP program. Now I am expecting if there is any questions from your side, I would be happy to give the answers. Any question from the injection, any question from musculoskeletal ultrasound, or anything, or any diagnostic parameters, we can ask the, we will try to give you answers. So we found Dr. Hassan sir has raised his hand, so you can type here, sir. I will try to give the answer. We have the moderators. So Niranjan sir, Bardhaman Jain sir is there. They are our moderators. So sir, you can, injection therapy is valid for physios in India. Yeah. Navin sir asked the thing, injection therapy is valid for physios in India or not? All right, sir. The first one is what I want to tell. It varies from person to person. It varies from country to country and state to state. So I believe that some of the areas, it may not be entitled at India. Some of the areas may be entitled, but most of the time IAP guideline is the most important thing for that. Anyone can do the courses with you. You can learn it, but during the practice, before doing the practice, you must ask IAP that you can do it or not. Most of the time, I believe maybe not. Most of the time. So it depends on your own association's rule. If IAP did not permit us, that means we are not permitted. In Bangladesh, what we can tell, in Bangladesh, our association permits us. Still, we are not getting final outcome from the government, but our association allowed us to do the injection. Harshal sir, right here. Harshal sir, right here. How much the fees for diploma? All right, sir. How much the fees for diploma? Previous time we go with the diploma program with Physio Health Institute. So Physio Health Institute can tell about the fees. This time we are going for COMP, Certificate in Orthopedic Medicine Practitioner. Physio Health can also tell you the fees for that. The fee, according to the fee related issues, please contact with Deepak Zindal sir and his team. They can tell you about the fees. Navin sir asked, so what's the use of this therapy for physio? Okay, sir. The injection module or the clinical physios. Okay. Orthopedic medicine is not only injection, sir. Orthopedic medicine have transverse friction massage. Orthopedic medicine have grade A mobilization. Orthopedic medicine have grade B mobilization. Orthopedic medicine have manipulation. Orthopedic medicine have rehabilitation exercises. So giving injection is only one of the tool. So you can deduct the tool also. There are so many countries of the world where Syriacs is running their program, but they cannot do the injection. We are using some other options also. Transverse friction is a very strong tool. Grade A and grade B mobilization, grade C manipulation, these all are very strong tool, what we can still use. And the final one is we are doing a strong rehab protocol. If you follow our strong rehab protocol, you will find lots of benefits from your patients. So that is the thing, sir. Injection is only 5 to 10% of our part. That is not all the things. OnePlus Nord had written, when will be the next date for diploma in orthopedic medicine? I believe Deepak Zindal sir can give you the answer for that. Already we have planned from the May, we are going to start the things. From May at Delhi, we are going to start our second program. Any other questions about our clinical things? Yeah, is ozone therapy and injection therapy are one? Yes, sir. We want to tell you one thing, that anything you are giving inside the patient's body through a needle, through a injection needle, that is injection or infiltration. So ozone is some people practicing ozone, but still in orthopedic medicine, we don't practice ozone therapy. We still don't practice ozone therapy because in the spine, if you want to give the ozone therapy, you need to have the C-arm. Without C-arm, you really don't know where you are giving the ozone therapy. So in orthopedic medicine, we are not using ozone, but prolo is a very good concept for us. Prolotherapy means 12.5% glucose. That glucose can be done by dry needle. That glucose can be done by hypodermal needle. That means the diabetic needles. So this thing is allowed for the physical therapy practitioners. So you can practice prolotherapy, but ozone therapy at India, I believe it is not permitted. Can physio do US guided dry needling in India? Rohit Sharma sir asked it. Sir, at India, I know that, or prolo in India. Sir, prolo, I believe people can do, because prolo, there is no chemical agent is used, and needle is not the only one thing to do the prolo. Even with the dry needle, you can use the prolo. So if your law is not permitting injection, you can go with dry needle. Dry needle with the prolo is a very good option for India, I believe, because there is no harm for that, and the authority is not restricting dry needling. Every physio is doing dry needle. So if you use the dry needle as tool of your prolotherapy, I believe you can use. But I believe ozone therapy may not be permitted at India. And sir, Rohit sir asked, can physio do US guided dry needling in India? First question, the answer is very difficult, sir. If your hospital have a ultrasound and there is a radiologist with you, Of course, you can do the dry needling under the guidance of radiologist, right? Radiologist standing side of you, you use the ultrasound. But I know that the law of India is not permitting ultrasound for every person due to the sex determination. So I believe with the supervised practice, you can do dry needle under the ultrasound, but independent practice, I believe it would be difficult. Bardhaman Jain sir is there, so I believe Bardhaman Jain sir from India, he can give the best answer for that. I believe independently you can't do with ultrasound, but with supervised practice you can do maybe. Falguni Onil ma'am, how do we test subcoracoid bursitis, sir? Yes, ma'am, that is a very interesting one. So what we said, the subcoracoid bursitis, first we do the scarf test. This scarf test give us 3 clinical parameters. One is AC joint can be positive, subscapularis muscle can be positive, and subcoracoid bursitis can be. After that, what we do a passive lateral rotation of the patient. If the passive lateral rotation of the patient gives us pain on the anterior part of the shoulder, we can confirm it is a subcoracoid bursitis, not AC joint, not subscapularis. All right, ma'am. So what we do, we always believe on cluster of the tests. Only scarf test cannot confirm the subcoracoid bursitis. All right, ma'am. Hope I have give the answer. Hassan Al-Banna sir, right? Sir, you can say something about Chinese traditional therapy. No, sir, Chinese traditional therapy, I really know nothing. Chinese traditional therapy is not part of our orthopedic medicine, so I can't say anything about Chinese traditional therapy. Any other person to ask anything? Any other questions? Bardhaman sir and Niranjan sir and Deepak sir, if you are there, then if there is no other questions, I believe you will give a small speech and then we can finish the things. Oh, sir, we are how to unmute, allow participants to unmute themselves that I have given. So all Deepak Zindal sir, you can unmute yourself and please give
Thank
us
you.
the speech, sir.
Thanks, Dr. Saizal. सर बहुत इंफॉर्मेटिव चीजें आपने शेयर की हैं और फॉर सर्टिफिकेशन इन ऑर्थोपेडिक मेडिसिन you can contact me anytime. We are going to start this certificate course in May. We have 5 seats left. So whomsoever is interested, just WhatsApp me your name and mobile number. I will send you the details. And thank you, Dr. Saral sir, for all this your sharing of knowledge.
Thanks a lot, sir. It's a great honor for me also. So it's a great honor for me to present something with our international colleagues. Thank you all.
Thank you, sir. Dr. Niranjan,
Yes, sir.
please